we have a star. He's not a movie star. He's a surgery star. He's a spine surgery star, and he's with West Boca Medical Center. I mean, that's where he does his surgery in Boca Raton, and it's such a pleasure to have someone of his capability, Dr. Sahai. You know, it's very scary, and I'm sure that's what you hear about it. But I have met a lot of people who have had the privilege, as a matter of fact, of having spine surgery, and their life has changed. So let's move all the way back to when you first went to medical school. This was a hard specialty. Why did you do this?
Yeah, that's a good question. So when I was actually finishing medical schools, I actually decided between orthopedic surgery and neurosurgery. And those are the two specialties that actually involve in spine. And I was fortunate to run across some really good mentors that I think influence you as a young doctor. So, it's, you know, you always want to emulate what you see around you. And I think I was fortunate to have some of those people around me. And so I was deciding between orthopedics and neurosurgery. And I like the ability to handle multiple things all over the body and to take care of not just spinal problems at that time, but also orthopedic issues as well. So with orthopedics, it allows us to take care of hips, knees, shoulders, and the spine. So, and the overall field appealed to me a lot more. So I ended up going to orthopedic and then specializing in spine surgery through that.
I see. So I would say, though, in most medical specialties, there are, I would say, improvements. You know, when doctors first started dealing with spine surgery, I'm sure it was a lot more difficult. So what's happened over the last, 20, 30 years?
Yeah, actually, even when I finished fellowship compared to what I do now is different. You know, when I finished fellowship training, they were saying, don't do multi-level surgeries unless you really need to have to. And then we were doing big open surgeries. So we were opening up the entire back, going through the front and the back, and doing all sorts of, basically what you would consider maximally invasive surgery, as opposed to what we do these days, which is minimally invasive surgery. So even after I finished fellowship, I actually traveled the whole country, found the best places, and went to learn from them. So I learned everything from big scoliosis surgery to minimally invasive surgery. And I went and found the people I thought were doing it the best at that time, and continually through conferences do that now. So the biggest thing is that, we recognize where the anatomy is, and we're able to accomplish the same tasks through big open exposures that we're able to do in a smaller setting. So smaller incisions through the use of technology, whether it's navigation, microscopes, X-ray technology. So just a bunch of different things. But, the basics stay the same.
So Dr. Sahai, I have to, I want to re-ask you a question in my mind as you were talking. I'd like you to repeat something for me, because I think everybody needs to hear this, that what was it like 20, 30 years ago when you probably weren't even practicing, but it was such a delicate operation, and sounds like it's changed a lot. What's happened?
Yeah. So, I've been in practice only 12 to 15 years, but I can't speak to 20 to 30 years, but I can tell you, even when I finished fellowship, it's a lot different than what I do now. So I think in relative comparison, you would call it maximally invasive surgery compared to what we do now, where, if we had to go from the front, you get a big open incision or big open incision in the back. And so even after fellowship, I went and learned from the best places in the country that were coming out with the newest stuff. And whether that was scoliosis surgery or less invasive things, I spent the next 2 years after actually when I started practice in Boca here, I went all over the country and found the best places and spent time there and learned how to do all these things. And I've been able to incorporate that. And now we're able to do things in a smaller capacity that people go home the next day from in surgery. So things that used to take, 4, 6, 8 months to recover from now can take 6 to 8 weeks. Minimal blood loss, the transfusions are less, pain meds are less. So, I think we're able to do a lot more. And the goal is to obviously do a similar type of surgery that we used to do, but now you can do it through less invasive means.
Let's talk about the age of your patients. Mm-hmm. Do you worry if someone is much older, or does it not matter?
It's a funny thing. Obviously, from a surgical standpoint, there are different pathologies that you see. So, I've taken care of everything from the sports teams at FAU, where we deal with the young football players and injuries, all the way up to the geriatric patients. And used to be that 70s was considered old. Now, mid 80s is considered, reasonable, and they've even operated to people in their 90s at this point. So, the good thing is that with the, quote unquote, minimally invasive or less invasive surgery that we do, with the blood loss being less and the anesthesia techniques being better, we're able to do these surgeries in a much more rapid ability and capability. And that allows the patients to actually recover. So where that the hardest part of the surgery would actually be anesthesia and recovering from that more than anything else.
That's an interesting discussion. So,
Yeah.
so you have to make sure, do you choose your own anesthesiologist?
Well, one of the reasons I work at the hospital where I'm at is that because they are actually, very good. So I have a lot of faith in the team and the people that we work with. And so, we have the ability to choose which hospital we work at. And so one of the reasons I continue to go to the hospitals that I go to is because the anesthesia staff is good. And we work together regularly, so we all know what we're doing.
Yeah, it's very important, of course, because here you are, you're the specialist, and one silly little mix-up, not anything you've done, could cause a problem. So you're very smart to do that. Well, let's just go into, so as an orthopedic surgeon, do you do other things besides spine surgery?
So I started out my career doing that, and I do some less so, but mostly I focus on spine surgery at this point. So I used to do all the trauma work, I do hip and knee replacements, do the scope work. Right. But now the spine surgery stuff has gotten so complicated and so involved that I stick mostly to that. Okay, so someone comes in and they're are they bent over or are they in pain? What are their problems when they first walk in? I mean, the most common things that we try to differentiate from is it nerve pain? Is it nerve compression? Or is it back and back pain? So whether it's nerve compression or not versus a back pain type of scenario, and then how structural is it? But the biggest things that we look for and that surgery is indicated for is nerve compression, whether it's in the back or the neck or in the thoracic spine or the spinal cord. So the main concern that we always have are the spine. One of the functions obviously is stability, but the other is to protect the nerves. And so when the nerves get jeopardized, that's when we are looking for intervention at that point in a surgical capacity. And this is a crazy question, but do you have any people that you don't think that you can help, and would you tell them that? And what kind of people would that be? Yeah, no, there's a lot of variable indicators for it. So, spine surgery is expanded. So, one of the things that we learned in ortho is just because, you're a hammer and everything is a nail doesn't mean the two have to connect, right? So we're very careful as to what we operate on, because time has shown that back surgery doesn't fix everything, neck surgery doesn't fix everything. So you have to do them in limited indications. So you have to know exactly what you're treating and what you're treating for. So just because you're fusing a back doesn't mean that you're doing it the same reason for an instability or nerve compression versus a scoliosis. They're all fusions, but they're different types of fusions. So it's important to understand what type of surgery you're getting and the indication that you're doing it for. Yeah, that's really important. And I can see the person saying to you, "So doctor, will it work?" And you have to be able to be that know-all person that says yes, or, well, we have to work on it, right? And so you did say that, would you ever do it in pieces instead of doing it all at one time? Is that what you were saying? There are times. So there are actually times where I stage scoliosis surgery, for example. So we do some things from the side or the back or the front, and then turn you to a different direction. And so we're able to figure out through less invasive means. Sometimes I scan you in between stages, or we stand you up to see how much correction we've gotten. So we do smaller surgeries at once, and rather than an 8 to 10 hour surgery all at once with a big blood loss. So there are different times where you can do smaller operations, bigger operations, or staged operations. So once again, it always comes back to knowing what you're doing the surgery for. Right. So Dr. Sahai, it's a very interesting thing to have someone like you, because you are young and you are in a field that probably has even more room to grow. I mean, maybe, are you using robots? Yeah. So that's one of the interesting things. That's one of the things that attracted me, because I have an engineering background in this field. And so because of that reason, it's one of the reasons that attracted me to orthopedic surgery in the first place. And so because of that, you can actually see the height of new technology coming in rapidly. So we get to play with all sorts of new toys and instruments. And one of the things that have steadily improved is actually robotics and navigation. So for complicated surgeries now, we actually do use navigation. So it's a instruments hooked up. So it's almost like playing a video game where you're with precision of millimeters that you're able to implant screws and hardware into a spine in very dangerous territory and get it in there with millimeter precision accuracy.
So your kids, so if you have children, you're letting them play on their video games because and did you do that as a kid? Is that why you?
Actually, to some degree,
really?
I did. And so it's funny you look at that because the hand-eye coordination, some dexterity did come from that.
So maybe not everybody's cut out to be a spine surgeon because some people, probably that's pretty tricky. It sounds like to me.
Well, I leave that qualification for other people, but I was fortunate enough to be able to do it.
Right. Okay. So now let's talk about you said scoliosis. What are the other problems that people have? I mean, accidents. Some people have been in terrible accidents and they've had broken backs, or what else?
Yeah, I mean, so accidents are actually one of the funny incidences where there's some things that go, small things to big things. So I actually had a young kid actually about 4 months ago, and he had a bad burst fracture where he was about such a bad car accident that the vertebra actually shattered and then went into the spinal cord.
Oh my heavens.
He was actually able to do that through a couple small incisions, and he was up walking within and doing most things within 6 weeks. So the things that we're able to do now, that we're able to apply less invasive principles even to horrific situations. There's tumor surgeries, there's pinched nerve surgeries. Most of the stuff is, what we consider quote unquote degenerative, right? Which is arthritis sets in your spine, the disc collapses a little bit, the nerves get pinched, and they require either opening from a laminectomy or an opening type procedure to a fusion type procedure where we have to stabilize and open it using hardware.
So I'm going to ask you a question I'm sure everyone would like to know. Why are we shrinking? Isn't that something to do with our... Tell us about the shrinking and what we can do.
The shrinking that you see, or the bending over that you see. So the discs are the main culprits. So just like you have hips and knees that have cartilage, the discs are cartilage, and they wear over time. So they start out at 14, 15, 16 millimeters in the lumbar spine, and, a little higher and a little lower in the cervical spine, and then they start to shrink. But they don't shrink symmetrically. So they don't shrink like this, they shrink like this or like this. And so depending on how your alignment, how you stand, you start to either lean forward, right, or off to the side a little bit. So there are a couple of things that play in a factor, but because overall, water is a big source of that. So as we get older, your tissues dehydrate. And so the discs start to collapse. And when they do that, you start to lean forward. And so, you have 5 lumbar segments, 12 thoracic segments, and 7 cervical segments. So just the combination of, those segments alone, there's a disc between each one of those levels. So it's, a couple millimeters throughout all those segments now start to lead to inches.
And so are you saying we should be drinking a lot of water? Would that help?
A lot of water. And then the other issue is osteoporosis. So then the bones start to compress too a little bit. So they can settle over time as well. So osteoporosis is where the bones start to thin, right? So the bones are structural scaffolds. So they start out big sort of rectangles and squares, and then they sort of shrink down and they become wedges, right? So you start something like this and they start to wedge, or they collapse a little bit. And those things, once again, sequentially happening at multiple levels now cause you to shrink.
So it sounds to me like it's posture. So what kind of exercises should we as older adults do to try to prevent this?
Yeah, 90% is just walk. The ability to walk becomes an underestimated thing over time. But what I tell a lot of my patients that suffer from postural issues is just put yourself against you put your back against the wall. Put your shoulders and your hips and your buttock against the back of the wall where your heels meet, and then stand up straight. So when you're standing up straight, you can sort of see where your alignment is supposed to be. And different things tend to tip us forward, whether it's hip issues, knee issues, whether it's a spinal issue in the lower back, and they start to tip you over. Then you get sort of stuck in those positions, and then you sort of start to develop ways to keep in those positions.
So are there trapeze that we can reach up? And I don't know if you can see me doing this.
Yeah, I can.
You can. And can we just reach up and hang on or something? Would that help?
Yeah, so if you could hang every day.
You
The
know,
biggest thing is just walking.
my father lived with 88 and had great posture. He used to have that in his house.
Yeah. I mean, look, just basic exercise, right? And it's underwhelming, but swimming, biking, walking, and just walking with the normal posture becomes an important part of this, right? Because what happens is you develop a knee or hip issue, for example,
Yeah.
and that throws your back off, right? Then you start tilting, and all these things sort of add up to one another. And then that becomes a longer term issue. This is why orthopedics becomes an interesting field, because, you know, the knee bone's connected to the hip bone, right? So they're all connected, and then you start to see how you get thrown off.
Yeah. And so, how many surgeries can you do in a day safely? Sorry.
I operate at a little bit of a faster pace than most. So, and you know, West Boca, one of the things I like is that they have set teams for me. So I can do, usually I average anywhere from, you know, depending on how big the surgeries are, but anywhere from 3 to 6 a day.
No kidding. Well, you're right. The team, they have a great team, and you just go in. And I'm going to just say something a little bit strange. You know, we are all supposed to wash our hands, right? All of us now.
Yes.
But I remember watching the doctors, the medical movies, and boy, you all wash your hands all the time, don't you?
Oh no, right now, especially with what's going on in the world, you know, masks and hygiene and basically sanitation, right, has become a huge issue. And we're extremely careful to make sure about those types of things.
Yeah.
And especially in surgery, right, where there's sterile protocols.
Exactly. So when someone comes to you and the family's all there, and and then you tell them what needs to be done, and everyone gives you their opinion, and then you decide, and now they come to the hospital waiting for the operation to be over. You know, I don't know if you know how that feels when you're sitting there waiting, and you're waiting for the doors to open because the doctor's going to come out. And usually, do you have a good smile or something?
I try to. You know, the first thing, I walk in because everybody looks at you with anxiety, right? So the first word of my mouth is, everything went great, right? I'd like to be able to say that, right? That routinely, you know, the first thing I'd like to be able to do is look a patient or their family members in the eye. Yeah. Right. To make sure that they know there's no hesitation there, right? That your family member is fine. That's the first thing I lead with, just to make sure that everybody understands, look, you know, I know it's a surgery, I know it's a back surgery, I know it's a spinal surgery, but, you know, I know you're concerned, and that we understand that, right? So our priority is the, you know, the patient, right? And making sure their well-being is cared for, but obviously communicating with the family. And right now, when you can't always necessarily be with a family member because it's limited in the hospitals, the communication becomes a big issue.
So what are you doing for a family?
So now the hospitals are allowing one family member to be in the hospital, and obviously that's much better, because that means that you know, recovering people need to be able to see their family, and I think that actually helps in their overall mental and physical recovery, right? As well as emotional, spiritual, however you want to call it. Right. So I think that makes a big impact. But other than that, we have to, you know, call people on the phone, try to stay in touch with them. But the good thing with the minimally invasive stuff is that we were able to send people home the next day. So we'll put you back in touch with your loved ones as quick as we can. And then physical, let's talk about the rehab. Tell me what it takes. I mean, it varies depending on what kind of surgery you have, you know, but usually we recommend 2 to 3 times a week for about 6 weeks of therapy, right? So what ends up happening is half the people have sort of not walked correctly for the longest time. So we're teaching you how to walk. Right. So, all right, you have to put your legs out. The stride length has to be right. Your posture has to be right. We usually give you a brace or something that helps you stay supported during this time. So you know how to use the braces properly. So you have to be able to sort of, you know, do multiple things at once. And it's something, just learning the process of walking again normally sometimes is just the hardest part. Or if you have neck surgery, then we take the collar off, and then you have to start working on your range of motion. But your head feels like it weighs a ton because now you've been in a collar. So then you have to start moving your neck and your range of motion. So there's all sorts of things that we attribute. Basically, it's postural and range of motion are the first 2 big things. Dr. Sahai, so years ago, I remember hearing some orthopedic surgeons, and it was a certain procedure where they put cement in between. Is that still happening? Oh, yeah. What is that? Actually, talk about that process. Sure. Yeah. So we actually taken that process now to the point that we actually do in the offices. So it's called a kyphoplasty.
Yes,
So,
yes.
yeah, it's meant for bones, so not for discs, but for bones. So what happens is as you get osteoporosis and you get older, and if you had a fall or just, you don't even have to have a fall. It can just be because the bones have thinned out and they can't structurally support your own weight. Then the bones collapse over time like we talked about. And when it does that, you create a subtle fracture through the bone. And that creates a significant amount of pain. So there's been lots of studies and, there's a lot of arguments about what happened and what's affected, but we found a way to show that a kyphoplasty is one of the most effective solutions for this. So we go in there and just through a needle, actually, are able to go into the bone. In our office, for example, we do it under sedation, so that way it doesn't cause you pain. But the procedure takes me about 5 to 7 minutes. We put a needle into your bone, put a balloon in there to open up the fracture site, take the balloon out, and then fill that void with cement, what we call cement. But it's actually, it's like a filler. So it goes in liquid or thick, like consistency of like applesauce, and it thickens over time. And usually within 5 to 10 minutes, it hardens. But we fill that void so that the bone, it interdigitates into the bone so it doesn't collapse again like a fracture. And that allows the bone to be healed basically instantaneously.
That sounds like a wonderful thing.
Yeah. So we do it, unfortunately, routinely because we do live in Boca and we do live in South Florida. So the age population here is unfortunately more amenable to it.
And I know that you probably don't deal in pediatrics, but have you ever, what's the youngest person you've ever had to deal in?
In practice here, I mean, obviously, in orthopedics, we have dedicated rotations in pediatric orthopedic surgery. So we deal with babies all the way up. So congenital abnormalities and things like that. But I've sort of limited the scope of my practice. So the youngest I'll do with spinal conditions is about 13, 14 years of age.
Mm-hmm. Yeah, it's, people don't realize, but when your spine, if you don't have a problem, you don't think about it. But have you ever taken anyone who's been in a wheelchair and all of a sudden you figure out what to do and now they don't have to be in a wheelchair anymore? That's called success, isn't it?
It is, multiple times. Fortunately or unfortunately, sometimes it's unfortunate a previous surgery didn't go so well, or, a situation that's been ignored for too long, or something that, hasn't been picked up and sort of served the right way. So whatever it is, what we try to do is measure twice and cut once, right? And so figure out exactly what it is that you need to have done, have an idea exactly what needs to be done, and then execute on that idea.
Yeah, I'm sure they call it revisions, right?
Yeah,
they do that with the legs, the hips, and the knees. Well, it's been interesting having you talk about this because I think that most people, when they can't walk or they have terrible pain, they then get on pain pills rather than have surgery, don't they?
Well, and they think that that's a solution that's effective, and we've realized, unfortunately, over time that it's dangerous. It's in fact more dangerous, right? Because pain pills do a couple of different things. They can be, obviously, number one, the worst thing is that they become addictive, right? Yeah. And that in of itself is demonstrated dangerous potential. Second thing is you ignore a situation where you either can no longer feel it or no longer aware of it. And then that leads to a progressive deterioration. So we get a lot of patients that come in and say, well, the pain pills are working. Why do I need to have it fixed?
Oh, really?
And you look at them and you say, look, the pain pills, they work for a little while. So, assuming you're a normal individual that doesn't like the feeling of pain pills, right? What happens? You take 1 or 2 pills. That works for a little while. Then you need 3 or 4, right? Then you need 5 or 6. And the tolerance keeps growing. And actually, even our geriatric patients say, well, I don't want to have surgery. I'm afraid I'm older and I don't want to have it.
Yeah.
And normally, we don't try to ever encourage you to have surgery unless you really need it. But then you have to look at the deficits you're encountering. Well, now you have weakness in your legs, right? You're losing sensation, right? You're not standing up straight. I don't feel it though. I have pain medication. Well, when you're bending over and you can't walk straight, even if the pain medication takes the pain away, pain is only one component, right? There's physical function, motor strength, sensation, things of that nature, feeling your legs. If you can't start to do that, you're a detriment to yourself by taking the pain pills and ignoring symptoms that are getting much worse. Remember, pain is usually an indicator that something's wrong, right? So to continually ignore something that's wrong is doing yourself a disservice.
Oh, this has been just spectacular. So I just want to tell everybody again, Dr. Ashish Sahai. Did I do that right?
Yes, you did.
Okay. And of course, we're just so fortunate to have West Boca Medical Center um, have you working there with them. They're a great hospital, and you're very special. It's been just joyful. I mean,
Oh,
I
thank
hope
you.
I never have to come to you, but if I have a problem, I'm certainly going to knock on your door. So would someone refer you? Is that how it works? Say, my physician would refer you, or an orthopedic surgeon who doesn't do what you do would refer? Is that how it works?
Actually, we just take everybody at this point. So you can do our referral, but now you can call us directly. So we used to just work by referrals only, but now, we're in a situation where the way the healthcare system is, it's just, there's too many moving pieces.
Well, we're glad you're doing this, and thank you so much for being an important physician in the Boca Raton community. I appreciate you taking your time. I know you're tired. If you've done 6 surgeries today, oh my gosh. Anyway, go home, have a good dinner, and play with your kids.
Thank you. I appreciate the opportunity. Thank you for
Yeah, it was great talking with you. Thank you.
All right. Have a good evening.
You too.
Okay.